Great. Good evening, and thank you for coming. So some of you may have seen a recent article in the Seattle Times which showed how life expectancy varies across King County as much as 10 years, very much depending on zip code. And what you can see is that it's worse in the orange areas in the southern end of the county. And my own work focuses on the health of Latino and specifically Latino immigrants in this area. And you'll notice that that is also the area where Latinos live in King County. The darker green areas being the zip codes that have larger Latino populations. So when researchers look at examine Latino health disparities, they've noticed what they call the immigrant paradox, which is that immigrants have better health than those born in the United States, even with similar socioeconomic status. However, immigrants' health tends to get worse over time living in the United States. And this is a pattern that's been documented across a number of different health conditions, including childbirth outcomes, diabetes, and mental health. And when we think about why this happens, most of the research has focused on the process of acculturation, that immigrants lose something protective about their culture or lifestyle in their country of origin, or that they're adopting something unhealthy associated with being American or living in the United States or an American lifestyle. My research tries to dig a little deeper and understand how social factors like racism and discrimination, immigration policies, and social and cultural contexts of migration influence health patterns. So we know that both men and women, immigrants that experience the same stressors in terms of social isolation, language barriers, lack of opportunities in terms of education and access to health care, but it impacts their health differently, these stressors. So, for example, for Latino men, one of the ways that we see immigration-related stress is in terms of their rates of binge drinking. And so here you can see that for Latino men, the rates are much higher than even just men in general in the US and Latinos in general. And for women, we see the immigration-related stressors often show up in terms of mental health disparities. And so here you can see that Latino women are at higher risk for rates of depression compared to Latino men and then men and women in general in the US. And so my research not only focuses on documenting these disparities, but also trying to design health promotion programs to address them. So one of these is called Vida Pura, and it's a cultural adaptation of an existing evidence-based intervention to reduce unhealthy alcohol use among Latino day laborers, who are a particularly vulnerable population among Latino immigrants. So we train promotores, or lay health workers like Roger and Yvonne, to actually go to a day labor worker center to offer a brief counseling session around alcohol use. And this is something that's typically been done in primary care, but we're increasing access to it by offering it at the Day Labor Workers Center through lay health workers in Spanish. And so the promotores provide personalized feedback on a tablet that actually shows what the men report in terms of their own drinking levels and how that compares to the guidelines for drinking. They encourage behavior change and help the men make a plan for reducing their drinking if they want to. Another program I've helped develop is called ALMA, Amigas Latinas Motivando al Alma. And this is a program to help Latina women prevent and reduce stress and depressive symptoms. And so it's an 8-week class. It's a group-based class that promotes self-care and social support. And some of the topics include how stress influences the body, how migration influences our mental health and our social networks, and healthy ways of coping with stress, like teaching new approaches such as yoga and mindfulness. And then we also help them seek mental health treatment if that's something they decide they need. So this slide shows some pictures of the women in the yoga class and some quotes from them. I really liked the yoga because it helped me to rediscover myself and my values. It helped me to meditate in my own space and change my thoughts to be more positive. The classes have helped me love myself more, meditate more, know myself deeper, and learn to relax. And both of these projects actually take place at Casa Latina, which is a social service agency here in Seattle. And community partnerships are really just essential for this work. Being able to do these interventions or these health promotion programs in a place that's trusted by Latino immigrants where they already feel comfortable seeking services has been really helpful. And I also try in developing these programs to really build on the strength and resilience that already exists in Latino immigrant communities. And I think that's especially true with the ALMA program. The other great thing about doing Latino health disparities research is that it really provides an opportunity to help train and mentor and develop the skills of diverse staff and students in our school. And so here is, you see a picture of Vanessa Torres, who was one of my PhD students, presenting her very first poster, which she was very excited about. So thank you.
So my question for tonight is thinking about public health. Well, what does work have to do with it? And clearly, being an industrial hygienist, my professional identity, we think we know how the workplace affects health, and we've had our traditional way of thinking about that has a lot to do with safety hazards and chemicals and dusts that people breathe in and affect their health in various ways. Over the past few years, we've been sort of questioning that paradigm and asking what the future of occupational health really looks like. And with my students and staff and colleagues in the School of Public Health, particularly Marissa Baker, who's here tonight, and Trevor Peckham, we've been thinking deeply about what it is about work that affects health and how we can transform the world of occupational health to be more responsive. So this is the traditional kind of concept that our field works with, that the nature of the work that you do determines the exposures. And again, silica, asbestos, benzene, all the traditional chemical hazards, noise and radiation, the physical hazards, that if you have exposure to those kinds of agents in the workplace, that you're more likely to get either disease or injury coming from those things. And that it's a very nice linear relationship that we can control by controlling the exposures. We can do surveillance and see where the failures are and try to prevent that disease in culminating in more severe morbidity and mortality through occupational health nursing and medicine. But this just doesn't seem like a very satisfying view of the world that we're living in. So this is an aluminum smelter in eastern Washington that we did research in about 20 years ago. And this is the kind of corporate industrial environment in which this model of work giving rise to exposures, giving rise to disease and injury has worked very well, and it's really the way in which we develop these ideas about how to control work-related hazards. And in fact, the whole regulatory apparatus that we function under, OSHA, is very much in this context of a large manufacturing facility with engineering systems that can either fail or help to get the product out and prevent disease. But that's not so common anymore. Here is a scrap metal yard in South Seattle that we worked in, working with labor and management, their health and safety committee, trying to get them up to speed on what they really needed to do to prevent these kinds of very frank hazards from taking a toll on the largely immigrant population working in this environment. And these people are exposed to a lot of metal fume, including lead and other toxic metals, and they have personal protective equipment, which is only somewhat effective in preventing exposures from happening. Here's another workplace. This man is not making milkshakes, but is preparing polyurethane foam to create trays for hospital services, food services. He's using very rudimentary, sort of patched together equipment, the drill with a piece of tape around it, to mix up polyurethane isocyanate chemicals known to be very allergenic. They create very severe asthma, whether you breathe them in or get them on your skin. Clearly, he's not going to be protected from either of those hazards, except for very minimally on his hands. This kind of small workplace, it really kind of flies underneath the radar of the OSHA regulatory apparatus and presents some pretty severe hazards for people working in that context. At least he has an employer, though. These are day laborers in Seattle looking for work, and those that were lucky enough to find work. I worked with Casa Latina, the same organization that India mentioned, to try to first examine what kinds of hazards day laborers face when they get to the job site. And we documented an injury rate about 1 in 3 workers on a full-time basis have an injury every year in this work. But they don't have anywhere to go with that. They're largely undocumented immigrants. They're at a great disadvantage for for creating a safer workplace, and their employer takes very little responsibility for the work that they're asked to do. They're really kind of an independent contractor in the eyes of the employer. That trend towards sort of independent contracting and lack of responsibility among the employer has taken an even further step in the last few years, what we call TNC drivers. That's transportation network companies, otherwise known as Uber and Lyft. Where is this guy's workplace? Who's his employer? Who's responsible for the working conditions, and who's responsible for injury and illness that might occur in that situation? So we took up these questions with a class, an MPH class, this past quarter, and had them address some of those issues in close coordination with the organizations that are working with TNC drivers. That is, what are the health consequences and safety consequences of working very long hours that they work? What is the exposure both to them and of the public to infectious disease in that closed environment that they work in? And how do they deal with the potential for violent customers? And those are all very, very important issues to the TNC drivers, and we tried to engage with them through our student activities in understanding what could be done, or what the nature of the issue was, what could be done, and actually proposed some solutions to these organizations. And we understand they're taking some of those back to the drivers now and saying, what do you think about implementing some of these changes in the workplace that you occupy? So in looking at the changing nature of work and the decline in large industrial organizations, the shifting of economic entities from vertically integrated employers to shifting employment out and responsibility out to workers like the TNC drivers, we need a really much more comprehensive and holistic model of what work-related health looks like. And so we've been working on this model, and this is a somewhat simplified version of it, but you'll see the same 3 characteristics across the top. We still have traditional exposures that cause disease and injury, but that's just not the whole picture anymore. So we're trying to integrate and see how social determinants of health, and I guess geographic location, zip code, could be seen as a piece of this. Demographics, the social services available, the built environment and social capital that people bring to their lives and to their workplace, and how the workplace then affects those characteristics, are very important predictors of those exposures, but also the psychosocial environment, particularly stress issues in the workplace, and in fact material benefits that are very closely related to the type of work and the type of employment that an individual has, giving rise to both disease and injury, but also this concept of well-being, including mental health, self-esteem, and fitness kinds of issues. So there are lots of arrows missing from here, but I think the idea is that unless we think of the workplace as a real both consequence but also a predictor of people's life in holistic terms, and the consequences for that, we're losing a big piece of the picture. So I'm seeing work as a really central determinant of health. We know that employment itself is one of the best things you can do for health. Unemployment is very bad for you. There are, of course, the traditional hazards in the workplace that need to be taken into account, but stress, including things like work-life balance, the hours of work, the bullying and social dynamics within the workplace, and also material resources, not only wages, but also insurance and days off and things like this are very important pieces of public health that we need to incorporate into this model. So my research going forward, I hope, is going to look at what are the determinants of public health that affect people's health, the determinants of health that arise from and can be affected both positively and possibly negatively within the context of work, and how people are able to do that. And this is a central piece of the whole social disparities in health problem that we need to face. So thank you.
Good evening, everybody. I'm really excited to be here tonight and share the work that my team is doing to increase wellness opportunities in small and low-wage work sites. And a couple of people on that team are here, Debbie Passy, one of the students working with us, and Jeff Harris, chair of the Department of Health Services. So we got very interested in workplace wellness because if you care about adult health behavior and if you care about chronic disease prevention in adults, the workplace is really where you go to find them, right? You think about it, most adults in the United States have a job. And for those of us who are lucky enough to be employed full-time, this is where we are most days, half or more of the hours we're awake. So our health behavior happens, and often doesn't, while we're at work. And so we've talked a lot about zip codes, and in my mind at least, that's a discussion of where your house is. But I think a lot of us have at least 2 zip codes and environments that are shaping our health and our decisions a lot, especially those of us who have houses and workplaces in fairly different areas. The other thing that's exciting about workplace wellness is that we already have a lot of great information about what we should be doing in the workplace. There are effective evidence-based strategies that can help us access preventive care appropriately, eat more healthfully, be more physically active, and avoid tobacco use. And one of the key challenges, how do we get those effective best practices around wellness into as many work sites as possible? So my team got particularly interested in small workplaces for several reasons. First of all, they're unbelievably numerous. So if you want to figure out how to get something evidence-based into a lot of different places, there are a lot of small work sites, over 100,000 work sites in Washington state with less than 200 people in them. They employ over 1 million people in Washington, almost half of our workforce. When you compare these small workplaces to their larger counterparts, most of them are doing very little in terms of evidence-based wellness practices. They're not doing little because they don't see a business case or value or want to support the health of their employees. Many of those that we've worked with or surveyed or interviewed say, we want to do this. We don't have the resources. So they often lack any budget to put towards wellness. More importantly, even than budget, they might not have any staff time or any staff who have expertise in health or wellness. And finally, and this is another thing that makes our area fun, you all know that there's a huge corporate vendor market out there for workplace wellness. But only a small subset, in my experience, of those vendors are interested in small employers. So it's hard for them to go get help as well. And then I just want to talk quickly about why we're especially interested in these small workplaces that are also low wage, often in lower wage industries. And when I say lower wage industries, I'm talking about things like accommodation and food services, hotels, restaurants, retail, and some things that may surprise you, like education, social assistance, and nonprofits also have wages that are well below the mean wages in Seattle and King County. Small workplaces are more likely to have low-wage workers, so these interests really go together. And this graph shows you an analysis we did that was a national analysis of people employed in the United States. So we separated them by household income, and the purple bars show you people who have jobs who have household incomes more than $35,000, and the gold bars show you with people who have jobs who have household incomes of less than $35,000. This graph is a little unusual because everything's framed negatively. Everything on here is what we don't want. So we would want these bars to be close to zero. And yet, we see big differences by household income, with those who have low household incomes much more likely to have missed cancer screenings and much more likely to be current smokers. Now, glass half full, glass half empty, those disparities are not so pronounced in physical activity or in obesity. It's just that everybody has a long way to go for those. So to try to address this, we worked with the American Cancer Society, and we worked with them on an intervention that they had started called Health Links. And then together we ended up reshaping it and trying to test it a bunch of different ways. So Health Links provides small employers with free on-site wellness consulting. So it gives them access to an expert who can help them. We've been doing Health Links with employers with 20 or more workers. And their consultant, if you will, first gives them an assessment of their current wellness best practices, and then gives them tailored recommendations about how they could improve. She provides materials that are as turnkey and as ready to go as possible. She helps them form an action plan around implementing more wellness activities and provides technical assistance and troubleshooting along the way. And the other thing that's interesting about Health Links is that a lot of the best practices focus on workplace policies and the environment of the workspace. So really, we're trying to make the workplace a place where the healthy choice is the easy choice, as well as helping support employees to make healthy choices outside of work as well. And the behaviors that are included in Health Links are those I've been talking about: cancer screening, healthy eating, physical activity, and tobacco cessation. We've done several Health Links projects, but in keeping with tonight's theme and the map that India showed you at the beginning, I thought I'd show you one that we did in South Seattle and South King County. This was close to my heart because this is where I live, which apparently is going to be bad down the road. But we worked with about 50 small work sites who employ almost 15,000 people in this project. The way we score success in Health Links is how many of our best practices and to what extent are they doing them. So it's scored 0 to 100%. You might be doing absolutely none of the best practices, or maybe you're doing all of them, or somewhere in between. So at baseline, we found that this group of work sites was only doing a little over 20% of the best practices that Health Links recommends. At our follow-up, 6 months later, we found that they had more than doubled that to about 44% of what we recommend. And honest people could say, gosh, Peggy, you're excited about this, but that looks a long way from 100 to me. And it's true. But we think that for only 6 months of work, especially given how many best practices speak to policy, that this is very impressive growth. And we have some other studies where we've been able to follow them out to 2 years and have seen that a lot of these gains are maintained over that time, even after Health Links ends, and that there are some work sites who actually continue to adopt practices later on. This map shows you where Health Links is and has been across Washington State. So the gold stars show you completed Health Links projects. So the gold star in King County is what I was just showing you. The purple stars show you Health Links projects that are going on right now. The Purple Star in King County is a large randomized controlled trial we have of HealthLinks that's going on with about 75 work sites. The purple stars in the other counties represent partnerships with local health departments, where we're training staff within those health departments to deliver HealthLinks to small employers within their own communities. So to wrap up, there's a big need for help and support to implement evidence-based wellness in small and low-wage work sites. We think HealthLinks has the potential to be a real win-win for public health. It's giving us a path to reach work sites and employees who often are not served by more traditional wellness programs. And we think it could be a win for the local health department staff we're training as well, because it gives them a very positive way to connect with businesses in their communities. And some of the folks we've trained have told us, when we're forming partnerships, it's been really hard to get the business sector around the table. So we're hoping that training local health department staff in counties across Washington is going to be a sustainable way to keep HealthLinks going, and a way that we can scale it to more counties here in Washington and even beyond Washington to other states. Thank you very much.